There are few moments in healthcare that trigger instant mental spirals, like hearing a label attached to the word cancer. In prostate cancer, grade group is one of those labels because it sounds deceptively final. I'm grade group 2, he's grade group 4. The mind immediately turns it into a verdict. But in real clinical practice, grade group is not a verdict. It's a high-value signal, one of the most standardized ways to summarize what the cancer looks like under the microscope, so clinicians can estimate behavior and choose appropriate next steps. Grade group is powerful because it is biology-focused. It reflects architecture and aggressiveness on histology. It is standardized through expert consensus and later adopted into broader systems. And it is clinically actionable. It connects directly to guideline-based risk stratification and common management paths. Just as important, grade group does not tell you where the cancer is, that stage, and it does not act alone. PSA, MRI, biopsy, volume, and staging complete the picture. If you can internalize that difference grade is not stage, you'll cut your anxiety in half. For decades, patients heard Gleason score as the core grading system. Gleason is still central, but it created a major psychological trap. A Gleason 6 sounds like 6 out of 10, meaning moderate. In reality, Gleason 6, written as 3+3, is the lowest grade of cancer typically diagnosed today because patterns 1-2 are essentially not used for reporting modern prostate cancer in routine practice. That mismatch caused panic. So specialists created a clearer system. Grade groups 1-5, designed to communicate risk more intuitively. 1 is lowest, 5 is highest, while staying grounded in outcomes data. Grade groups exist for one reason: to improve clarity for patients and clinicians without abandoning the science of Gleason architecture. Here's the translation key you need. Grade group 1 equals Gleason 3+3. Grade group 2 equals Gleason 3+4. Grade group 3 equals Gleason 4+3. Grade group 4 equals Gleason 8, like 4+4, 3+5, or 5+3. Grade group 5 equals Gleason 9-10, like 4+5, 5+4, or 5+5. The most important insight is this: Gleason 7 is split into two biologically different categories, 3+4 versus 4+3, because the first number is the predominant pattern, and that changes the risk conversation. Now let's go deeper into what that means, how clinicians use grade groups, and what questions you should ask so you leave with a plan. A biopsy is tiny tissue. A pathologist looks at the architecture, how glands form, how organized or chaotic they appear, and assigns patterns. Pattern 3 tends to look more gland-forming and organized. Pattern 4 shows more fused, poorly formed, or cribriform architecture, and is often considered more aggressive than Pattern 3. Pattern 5 is the most aggressive architecture, often showing essentially no gland formation or very disorganized patterns. A key nuance clinicians care about is heterogeneity. Prostate cancer can contain mixed patterns. The Gleason and grade group framework captures that by summing the two most common patterns. But biology can still vary across the gland. That's why MRI targeting, systematic cores, and sometimes repeat sampling matter, because a small biopsy can undersample a larger truth. Let's make the most common misunderstanding painfully simple. Grade group is how aggressive it looks under the microscope. Stage is where it is in the body. Grade group informs risk. Stage defines extent. The plan comes from both. Now, what does evidence say? Grade groups track outcomes better than raw Gleason totals for communication and prognostic separation. They weren't created just to make patients feel better. They were built because outcomes data consistently showed that collapsing prostate cancer into 5 biologically meaningful bands improves clarity and preserves prognostic signal. And this is where the 3+4 versus 4+3 difference becomes more than semantics. The first number is the most common, dominant pattern. That's why major cancer education sources explicitly note men with 3+4 equals 7 tend to do better than those with 4+3 equals 7, even though both sum to 7. This is not about math. It's about biology. Grade group 2, or 3+4, means pattern 3 dominates and pattern 4 is secondary. Grade group 3, or 4+3, means pattern 4 dominates. 2 7s, 2 different trajectories on average. Now here's a truth clinicians live by. 2 men can both be grade group 2 and still not be the same. Why? Because the percentage of pattern 4 can vary widely. So the expert level patient question becomes, is percent pattern 4 reported? And if so, what is it? Even when the exact number isn't provided, clinicians often infer volume risk from the number of positive cores, percent involvement, and whether MRI-targeted cores are positive. Grade groups also feed into broader risk stratification. Many frameworks separate intermediate risk into favorable and unfavorable. Grade Group 2 may still land in favorable intermediate depending on other factors like PSA and how much of the biopsy is involved. Grade Group 3 more often signals unfavorable intermediate conversations. The point is that risk is multi-factor. Grade Group is one pillar. Now let's talk about biopsy reality, sampling error and upgrading. A biopsy is a sample, not the whole prostate. So two things can be true at once. Grade groups are meaningful and predictive overall, and individual patients may be upgraded or downgraded when more tissue is examined later. That's why MRI-targeted biopsy, systematic sampling, and sometimes confirmatory biopsy exist to reduce the chance of undersampling the dominant lesion. You can say it like this: biopsy is your best early map, but sometimes the map improves when we get more information, MRI, repeat sampling, or surgery pathology. There are also pathology nuances that influence outcomes. Within Pattern 4, certain architectures like cribriform are recognized and discussed in modern grading consensus. This is one reason clinicians may treat two Grade Group 2 cases differently. One may have limited Pattern 4, another may have more concerning Pattern 4 architecture depending on report detail. And pathology is standardized but not robotic. There can be borderline cases, especially around the boundary between Pattern 3 and 4. So, if your management choice depends on a borderline call, especially between Grade Group 2 and 3, it may be reasonable to ask whether a second pathology review by a genitourinary specialist pathologist makes sense. Now let's walk through Grade Groups 1-5 like clinicians do. Grade Group 1 is often considered low grade and may be compatible with active surveillance for many appropriately selected patients. But selected is doing heavy lifting. Clinicians still evaluate PSA and PSA density, MRI findings, number of positive cores, percent involvement, and patient preferences. Grade Group 2 is intermediate because Pattern 4 is present. The key questions become how much Pattern 4 and how much cancer overall. This is why some Grade Group 2 patients are discussed as favorable intermediate risk, while others are not. The message is that Grade Group 2 doesn't automatically mean you need the most aggressive treatment tomorrow. It means you need a thoughtful risk conversation based on your full picture. Grade Group 3 is still often categorized as intermediate, but dominant Pattern 4 changes urgency. Treatment? Here's the 1-minute summary you want to repeat. Grade groups are a simplified, science-based way to describe prostate cancer aggressiveness from biopsy. 1 is lowest, 5 is highest. They map to Gleason patterns, and the order matters. 3 plus 4 is different from 4 plus 3 because the first number is the dominant pattern, and outcomes differ on average. But grade group is not the whole story. Risk decisions also use PSA, MRI, biopsy volume, and clinical stage.
Everything looks good.
Your best move is to ask structured questions, so you turn fear into a plan. And if you're watching this at 2 a.m., with 14 tabs open and your phone at 3% battery, do yourself a favor. Close the tabs, drink some water, and remember, this number is information, not a horror movie. If this helped you feel clearer and calmer, subscribe to Nourish today. We turn confusing medical language into simple next steps with fewer panic spirals and more peace of mind. Legal disclaimer, this content is for education only and does not replace medical advice. Please discuss your individual case with your urologist or medical team. See you in the next video.
Thanks for watching. Stay informed, stay calm. Subscribe for calm, evidence-based health here on Nourish Today.